Welcome to our webinar today. The title of the webinar is Shining On Through Health IT, Lessons Learned and Looking Forward with the Beacon Communities. We've got a great lineup of presenters for you today that are going to talk about the Beacon program, a lot of their successes and what their plans are moving forward. So I'm going to introduce everyone that will be speaking with you today. Just to let you know, though, that at any point during the presentation, feel free to type into that box that you see on your webinar panel that says questions. Any question you type in there, once the presentation is done, then I'll be going through those questions and reading them off to the presenters. So again, at any point, just type in your question, and then we'll have an opportunity after all the presentations are over to do that Q&A. We also have this webinar archived up on our website, so you'll be able to download the slides and hear the audio version as well. So please, for your colleagues who weren't able to take time out of their busy day today to participate in the live version, let them know that they can still hear the presentation or look at the slides on our website. It'll be up in the next 24 hours. I also want to take this opportunity to remind you, if you haven't already, to register for our upcoming Fall PCPC Conference. This is our big annual meeting. It's in Bethesda this year, right at the Hyatt Regency above the Bethesda Metro stop, super easy to get to. The dates are October 13th through the 15th. This is the longest conference we've ever had. We're going to have all kinds of workshops, panelists, awards ceremony, lots of meetings that you'll all be invited to attend to learn about the actual work that's going on here at the PCPCC and get to meet all of our leadership. We have a special opportunity for all of you who are taking part in this webinar today. If you haven't already registered, at the close of this webinar, if you go to our registration page on our website and register for the conference and type in the code 9WEB2013, that's the number 9, WEB 2013, you'll receive $100 off of our conference registration fee. And that'll be available for the first 25 people who register for the conference at the close of this webinar. Again, the coupon code is 9WEB2013. We also have several publications that we'll be releasing very soon. So obviously, if you're participating in this webinar, you're getting our communications. But just to give you a heads up, this month we're focusing on population health, and we're going to be wrapping up the month with the release of our population health management guide. And then all of you, I'm sure, are familiar with our benefits of the patient-centered medical home guide. We're working frantically and furiously to get all the latest data and information about what's going on with medical home initiatives around the country to present into that guide so that we can really give an overview of where medical homes are really working around the country. Everyone who attends our conference will get a copy of those guides, but they'll also be available for you to download online. I mentioned that this month we're celebrating population health. We're going to wrap it up on September 26th with a national briefing. So we hope that you're able to join us then. Jan Sidorov will be talking about population health management in the patient-centered medical home. He's spoken on several PCPCC webinars in the past. He's a real expert in this area, so I'm sure that that will be a really informed discussion that all of you will be able to have live with him on that monthly briefing. So without any further announcements, I'm going to go ahead and introduce our speakers for today. Starting off today, we've got Genevieve Bertain. She's the Acting Director for the Beacon Community Program at the Office of the National Coordinator for Health IT. Again, Genevieve is a good friend of the PCPCC and has been generous with her time and given us updates on the Beacon program in the past. We welcome her back. And along with her today, we're going to have Lacey Hart, who will be representing the Southeast Minnesota Beacon community. Lacey's the director for the Center for the Science of Healthcare Delivery Project Management Office at Mayo Clinic, and Trudy Matthews representing the Greater Cincinnati Beacon program. Trudy is the director of Policy and Business Development with HealthBridge in Cincinnati, Ohio. So without further ado, I'm going to go ahead and turn it over to you, Genevieve.
Thank you, Amy, and our thanks to everyone for joining today. It's been such a treat to work and learn about all the terrific work of the PCPCC, and I want to thank Marcy and Michelle for their help getting this webinar together. We couldn't be more excited to share some of the background and lessons as we end the final stages of the program here, and I'm really excited because I'm joined by Trudy Matthews and Lacey Hart from the Greater Cincinnati Beacon community and the Southeast Minnesota Beacon communities, respectively. I'll talk a little bit about the context of the program, where we are as we think about the next chapter from the ONC's perspective, and then we will move to presentations from Trudy and Lacey. And then I'm hoping we'll have a good time to have some discussion and hear questions from each of you. Next slide, please. So for those of you who are thinking about the Beacon Community Program for the first time, you might be thinking, where are they? And on the map, it's been such a treat to be able to work with 17 such different places. San Diego and Detroit, down to the Mississippi Delta and New Orleans. This is a rich, diverse group of urban environments, rural environments, competitive hospital markets, markets dominated by one IDN. And our vision here was that this would be able to help others in the country find themselves in the experiences of Beacon communities. Next slide, please. And then the goals of the program across these 17 communities is to do 3 things. First, build and strengthen health IT infrastructure and exchange capabilities. That's everything from the wires with EHRs to exchange, you name it. The second is to improve quality, cost, and population health. We have a state HIE program, and while there's an exchange component, this was very much supposed to be about outcomes as well. So we did ask each Beacon community to tell us the population of focus and their target outcomes and look at that over time. And then finally, we wanted them to test innovative approaches. So things like remote patient monitoring and mobile health, it's still an act of becoming, and we need more evidence to understand what works and what doesn't. So many of the Beacon communities were testing new models. The amount was about 12 to 16 million per Beacon community, spread across multiple partners across the community, and it was done over 3 years. We are actually in a few weeks coming to the formal conclusion of the funding period. I'll talk a little bit about what the next chapter looks like, but certainly would look to Trudy and Lacey to describe what that looks like in their communities. Next slide, please. So I have got on the next couple slides for you a couple of the bright spots by pillar. It is impossible for me to be able to truly represent all of the amazing things that have happened. And it's important, I just want to emphasize again, that we are looking at 3 really separate marks of success around building and strengthening health IT, and that is an infrastructure investment because we, through high tech, needed this system to modernize. And then the second goal, as I mentioned, is around outcomes. But it's important to note that it's not only about outcomes because it takes time to get there, and we needed to make some infrastructure investments first. And third, we did want to look at innovation. So I'm going to spend a little bit of time, give you some brief highlights of some really interesting work that's happening, just caveat being that I'm not doing justice to the things that are on the page. So on page 5, talking a little bit about the first aim of the program around build and strengthening health IT. I'm going to focus on the Central Indiana Beacon community for a moment. Through their information exchange, they had a program called Quality Health First. Sorry, let's go back a slide. I'm not sure what just happened. I'm going to go ahead and read, but let's go back. Can we go back a slide? There we go. Thank you. So we're on page 5, the Central Indiana Beacon community. They had a really interesting program called Quality Health First. And as part of the Beacon, they expanded the reach of the HIE to cover 75% of the hospitals in the region, and also extended the reach of the Quality Health First program to touch more than 700 additional providers. So that's just that's a great example of an investment that preceded the Beacon, but was able to be built further. Now that's contrasted with an example of the Crescent City Beacon community in New Orleans. This is a community that actually didn't have any information exchange happening, and they said with their stakeholders that it was very important to support population health, that they wanted to bring the safety net community together, a couple of the hospitals, and really test out how exchange could help their outcomes, again, particularly looking at FQHCs. And they have information exchange live now, looking at some key capabilities that are going to affect more than 750,000 patient lives. So very exciting to see new capabilities coming to a marketplace that would truly benefit from it. Just quickly on the Keystone Beacon community in San Diego, the things that I think are really interesting is that they've pulled together interesting partners. So in Keystone, the long-term post-acute care community is really one that could benefit with more exchange to support care coordination. There's an interesting project called Key High Transform. And with San Diego, it's a very competitive hospital market. They've pulled a lot of players together, including EMS, which is a pretty exciting development. Next slide, please. So in terms of the second aim, improving quality, cost, and population health, again, we wanted to keep our eye on the prize. This is about outcomes, but I do want to emphasize that the program was much more than just about the outcomes, especially with the aggressive timeline of 3 years. One of the most remarkable things that we saw was the power of data to drive improvement. And one can imagine with EHRs that this is really, really a much more comprehensive approach and an easier approach that we are seeing now. EHR used to support empanelment and really understand what my diabetic list looks like and who I need to target. And so Bangor Beacon Community, Rhode Island Beacon Community, and Colorado Beacon Community are 3 places that have really used data to drive improvement, and that the foundation of technology helped them do that. Just some of the statistics that we're seeing here from Bangor, for example, they improved LDL control among patients with cardiovascular disease from 57% to 65%, just as an example. They also it's not on the slide, but they've got some interesting results around ER utilization decreases as well because of their care management capabilities and their care managers' use of technology. With Colorado Beacon Community, they really embraced a learning collaborative model to make sure that all the providers in their market were able to really powerfully use technology. And it's been, again, a really interesting approach to help people powerfully use technology in their practices to get to improved outcomes. Some of the details on the slide, again, improvements in LDL control with patients with cardiovascular disease from 48% to 59% in its initial cohort of clinics, and another decrease in a second cohort of clinics. I won't read the statistics, but Rhode Island Beacon Community, same experience, sharing data, using the data, and then using that to drive performance improvements. This is exciting because when we think about meaningful use, acceleration, and adoption, this is something that we could be doing in many more places across the country. There's some specific tools that I'm going to talk about in a little bit that make this possible. Next slide, please. Finally, a little bit about innovation. Again, not certainly describing all of it, but three cool projects I wanted to share with y'all. First, with mobile health. Huge expansion in this field and a lot of insight from Beacon communities about what's possible. One interesting one shared by 3 Beacon communities was called Text for Health. Their idea here was to help identify patients at risk for diabetes and basically bring them into the system. So a lot of people, one emphasis is, of course, if you know diabetes, you're already in a PCMH model. Another issue is, what about people who might have diabetes but don't know? So this was their test to use a mobile platform that got a risk assessment. There will be more data coming out about this, but again, an interesting and innovative model. Another one with the Utah Beacon Community, Care for Life, was more around mobile health and diabetes self-management. And then interesting, an avatar model. I don't know if those of you are familiar with Project Red, Louise, that was more of an avatar model around readmissions and discharge planning. They modeled that further to be used more around WIC, healthy eating, breastfeeding, and more with moms and babies. Again, an interesting adaptation of an innovative pilot for another population. Next slide, please. So the next chapter begins. It's hard to imagine that 3 years have gone by. We are, from the ONC's perspective, focused on a couple things, and then I wanted to talk a little bit about what it means for communities. First of all, you'll note that we're saying the next chapter begins. We're not talking about closure because the work in every single community is continuing, and it's being, the threads of it, the seeds have been planted for newer initiatives, bigger initiatives. Other work is continuing, and we are fully committed to seeing how this unfolds. From the ONC's perspective, we are going to be undertaking several evaluations. and several Beacon communities are actually taking their own evaluations on, to really understand what has happened, what hasn't happened, and talk more compellingly and clearly about the outcomes. And also things that didn't work, because one of the most profound lessons we think could be helpful to others in the field is some of the starts and stops from beacons. I hope Trudy and Lacey will speak to some of those, because that will be instructive on the path forward. So more to come from the ONC's perspective about this, but I think very much a next chapter is beginning and there is more work to be done. So with that note, I'm going to talk about a few things that we're going to be working on and have been working on in terms of dissemination. Next slide. So one thing that's important just as a foundational element is that the Beacon community experience in certain communities is already translating to different payment pilot models. And I mentioned Bangor Beacon Community before. They have actually become the Bangor Beacon Pioneer ACO, very much using the tools from Exchange to EHR to IT-enabled care management to support their new payment model. Others are part of the CMMI CCTP program to improve care readmissions, avoidable readmissions, and using things like ADT alerting. So we do very much see the Beacon Community Program and payment reform as very related and actually extremely supportive of each other, because some of these IT tools are going to be critical for success for some of the new payment models. Next slide, please. A really exciting program that has started with the leadership of the Hawaii Beacon community is the Beacon Nation Project. The Beacon Nation Project was basically an opportunity for all of the Beacon communities to come together and harvest the lessons learned. I'm going to talk a little bit about those in particular, but then the other thing that we are doing is working with issue briefs from Academy Health to share more about what's been happening. And then there's many, again, publications coming out from Beacon communities to share their individual experiences. You'll see a quote here from Patrick Gordon, but about the experiences, the networking, the trust fabric, and honestly, all the intangibles in some way that we are hoping to codify and cull and put out there for people to see, because one of our wishes as the ONC is to make sure that these benefits and experiences truly help others outside these 17 communities. Next slide. Learning guides. For those of you who see the slides, these are basically a promising IT-enabled intervention that can be deployed in a community to accelerate healthcare transformation. I've mentioned before, using EHRs powerfully to drive improvement. We know that that is working in several Beacon communities, and we wanted to figure out, how do we pull this together, not just for one Beacon community, but for several, and help others do the same thing. That is the heart of a learning guide. So the topics on here are, when we ask the Beacon communities, what are the 6 where we think you have some compelling experience, and we want to really codify this in detail for an implementer, not a policy audience, an implementer. These are the topics that we came up with. Admission, discharge, transfer alerting, IT and care management, capturing high quality data to drive improvement, information data exchange strategies to support community goals, clinical transformation, and then population health. So these are areas that, again, Beacon communities have some experience, and when we asked also the market, there was a need to see some of this information. There's links that you'll see about how you can get to them, but we're hoping that tools like these will be helpful to you on your journey. Next slide. The final part I just wanted to mention, because it's from the ONC's perspective, something that we'd really love to continue to do. We had an opportunity through the Beacon Nation project to test this, and it's around shared learning. So certainly we wanted to make these learning guides available, but we also wanted to actually figure out if we could help another community outside the Beacon program do something with not just the learning guide, but with the experience of the Beacon communities. And we've deployed 4 shared learning visits to across the country. Some of them are some quotes are from people who have participated in them. In Coastal Carolina's Health Alliance in North Carolina, and then the Metropolitan Chicago Healthcare Council as part of their exchange effort in Chicago. And the early results are, it was just incredibly helpful to have a higher touch shared learning opportunity to help sometimes validate their goals, and sometimes really just bat around some of those tricky issues that are best explored through a conversation versus just a web interaction. So if you have an interest in this, I think we are certainly from the ONC's perspective very interested in doing more shared learning with really interested communities and partners. With that, I'm going to turn it over to Trudy Matthews, and I will say a few words about Trudy, who it's just been a pleasure to get to know Trudy and see all the amazing work she's been doing in Cincinnati. She's the Director of Policy and Business Development with HealthBridge in Cincinnati, Ohio. It's a not-for-profit corporation that supports health information technology adoption, health information exchange, and innovative use of information for improved healthcare outcomes. For well over a decade, HealthBridge has been recognized as one of the nation's largest, most advanced, and most financially sustainable information exchanges. Since January 2008, Trudy has managed public sector development efforts, public relations, policy, and government affairs for HealthBridge. Trudy has given leadership to HealthBridge's successful collaborations for the REC program, the Beacon Community Program, the State HIE, and Nationwide Health Information Network awards totaling more than $26 million. It is always exciting to hear Trudy talk about the latest and greatest coming out of the Cincinnati community. So over to you, Trudy.
Great. Can you hear me okay, everybody?
Yes, we can.
Jonavi and folks? Okay, great, great. Thanks so much, Jonavi, for the introduction, and thank you to the Patient-Centered Primary Care Collaborative for the opportunity to participate today. And thanks to all of you for being on the phone and for taking time out of your busy day to learn more about the work of the Beacon communities. As Jonavi mentioned, I'm here to talk about Greater Cincinnati's Beacon efforts, and particularly around some of the things that we've done with population health. Get the slides to advance.
You just want to click in there and it'll give you control.
Okay. Let's see if it'll advance. So while we're waiting for the slides to catch up, Jonavi gave a little bit of background on the on HealthBridge. There we go. And mentioned that we're one of the nation's largest, most advanced and successful health information exchange organizations. We not only support health information exchange in Greater Cincinnati, but we also work with 4 other health information exchanges. And we're also a regional extension center in Cincinnati Beacon program. And we also just want to say as well, we also work really closely with 2 other organizations in Greater Cincinnati, the Cincinnati Health Council and the Health Collaborative. And actually one of the things that has been kind of unique about our community is as a result of the work that we did under Beacon, some of the changes under the Affordable Care Act coming along, our 3 organizations, HealthBridge as a technology arm, the Health Council as a hospital support organization, and the Health Collaborative as the quality improvement organizations now have all gone through a reorganization, and we're under a single integrated executive team. And so a lot of what I'm going to talk about today is not only what our strategy has been and what we deployed under Beacon, but also going forward some of the tools and capabilities we're using as a community to really improve population health across our community. So one of the things that's really important, one of the key strategies in all of this is the ability to measure at a community level the improvement of health. And so that involves, sorry, I'm having a little bit of trouble clicking in here and advancing the slide.
If you just kind of click right in where the presentation is, you should, like earlier, you take control.
Yep.
Well, if you'd like to say,
Unfortunately,
Michelle,
it's not advancing for me.
If you'd like to say the next slide, Michelle can take it over for you.
Okay, that'd be great. Super, I appreciate that. So in terms of there we go, Greater Cincinnati's strategy for helping, our focus of our Beacon work was really around 2 major conditions, around diabetes and asthma. And one of the ways that we worked on improving diabetes care was really using a set of community goals and community measures to bring everybody together to help accomplish our goals. It's not enough just to say we all think that it's good to improve diabetes care, but really measurement gives you some things that to shoot for. So in Cincinnati, we call our diabetes goals the D5. this is a composite measure of 5 measures for optimal diabetes care. Includes keeping your blood pressure under 140 over 90, keeping bad cholesterol under 100, keeping blood sugar under 8%, being tobacco-free, using aspirin as recommended. And so we have these common goals. Then we also have a public reporting initiative where literally hundreds, more than 500 primary care providers in our community now report their performance on these, and is posted annually through a consumer transparency website called Your Health Matters. I encourage you, if you want to, during the time I'm talking, just open up yourhealthmatters.org and start taking a look at what this looks like. We're pretty proud of this website. It is one of the highest per capita visit rates and hang rates of any consumer transparency site in the country, and was actually designed and put together by some consumer health experts with Procter & Gamble, which is located in Cincinnati. We're very fortunate to have those folks to provide their expertise. So on this site, consumers can see how their doctors compare on the D5 versus the community average. They can also see if their practice is recognized as a medical home and if the practice uses electronic health records. There's a host of diabetes educational materials on the site. And then in addition to the website as a consumer education tool, we also provide a host of practice-based materials that staff can then distribute. So I was in visiting a practice a few months ago where we were doing some patient and provider interviews, and there on the wall was a D5 poster so that patients can be invested in improving their own outcomes for diabetes. And so the practice uses cards, gives them little small cards for folks with diabetes to take home with them and to be working on it. And we even have one practice that the MAs high-five the patients if they met all their goals, and the MAs have a contest with one another over how well they're doing to get optimal care for their patients with diabetes every month, and whoever gets the highest score with their patients gets a gift card. It's really a great way for the practice itself to work on improving and really engaging patients. And again, community measurement, having a common set of goals and a common set of measures to galvanize that support is really important for population health. So if you go to the next slide. Another strategy, a second strategy that we've done, and really this is kind of a composite itself, a set of coordinated interventions, is really using a comprehensive care approach. And so let me tell you what I mean by that. There's no silver bullet in healthcare. Technology alone won't solve poor health outcomes. Just doing community measurement won't solve poor health outcomes. You really have to have a set of interventions that are working together. So in Cincinnati, we focused on 4 interrelated set of changes to support the delivery of optimal care in primary care practices. So under Beacon, we expanded the number of medical homes that are used, and all of you know about this great primary care practice model that helps support the management, improved care management for whole populations of patients. We've supported expansion of the use of technology, so meaningful use of EHRs, data exchange that connects across the medical neighborhood, the use of alerts for use of the ED or being admitted to the hospital. We're using EHR data to generate those reports for the D5, as well as using those kinds of reports for just monitoring ongoing how a practice is doing related to their D5 ongoing. And then finally, we also know that none of these changes in use of technology, the medical home transformation, are really sustainable unless primary care providers are paid differently. So our community was one of the 7 that was applied for and selected for the Comprehensive Primary Care Initiative, which is funded through CMS and 8 commercial carriers. So there are 75 primary care providers in our community that are being paid differently to support the delivery of comprehensive care that will provide better outcomes and lower costs. So those are 2 of our main strategies focused on how we improve population health, and I've talked mostly around diabetes, but let me talk about what this means for an individual practice. If we could go to the next slide. So when we started on this journey back in 2010, and I want to tell you what we've learned. I mean, we are true believers in technology and practice transformation, payment reform, but even we were skeptical, if we could go back one slide, even we were skeptical that could this all really be done simultaneously in a practice? Are we crazy to think that you can bite off all of this at one time? Isn't this just a little bit too much all at once? Well, yes, this is doing all of these things is a lot. Comprehensive care, community measurement, all of these things are a lot for practices to do. But working together, we can really accelerate the process of transformation. And one of the examples of this, and this isn't just the only example in our community, but it's one of the ones that inspires us because we really see that if Summit Family Physicians in Middletown, Ohio can do this, really any practice in America can do this. Because when we first started working with this particular practice, if someone had said, this is going to be one of your key performers, we would have said, no way. They really were not our best candidate for an extreme practice makeover. But with committed leadership and plenty of community support, this independent practice really turned things around in just a space of 18 months. So we first met them in the summer of 2011, and they had signed with the Regional Extension Center. At that point, the practice was, really not doing well. And so again, they weren't our candidate for an extreme practice makeover, but they were wanting to work with us and turn things around, and they were really committed. And so this practice got on board within 3 months. They were live on their electronic health record. Within another 3 months, they had were finished with their 90-day reporting period and had attested to meaningful use. That is no small feat in doing that in just 6 months. And they tested on December 30th, 2011 with 1 day to spare. At that same time, they were also selected to be part of our Beacon Patient-Centered Medical Home cohort, and we're also working on medical home transformation. Now, most times we tell people don't try and do both meaningful use reporting and medical home at the same time, but they were really committed, and so they were working on medical home simultaneously and trying to really work on, as they were doing clinical documentation for meaningful use, they were working on clinical documentation improvements for medical home. So they also, in the same period of time, publicly reported for Your Health Matters in both 2011 and 2012. They applied in late spring, early summer for NCQA recognition. They applied as a level 3, were only given level 2. That made them so mad that they went back and fixed their documentation, and then they were given level 3 medical home recognition in November of 2011. Well, some people say it can't be done, but I'm going to tell you again that there's really nothing special about the people of Summit other than their extraordinary commitment to improve. So they wanted to make care better for their patients. They didn't whine about what it takes. It was really hard work, and they were religiously committed to working with others to share the best ideas and really making this work. And they are an inspiration to all of us in Cincinnati for what they were able to do in such a short period of time. Next slide. Let me just say in closing, so this is why we do what we do, practices like Summit Family Physicians, and the leadership at HealthBridge, the Health Council, and the Collaborative. We have learned from folks like this who are doing really phenomenal, extraordinary work because of the commitment that they have and from all of their teams who are working together. And it's been amazing under the Beacon program to see this work progress, and we are even more committed than we have ever been to working alongside stakeholders in our community to support the spread of this kind of commitment to even more practices and to work together to achieve better care, better population health, and lower cost. So thanks for the opportunity to present, and I'm sure we'll have a time for questions toward the end, and I'll just hand it over to Lacey.
Lacey, bear with me. Hey, it's Genevieve. I'm going to do a very quick introduction for you. Trudy, thank you so much. That was fantastic, and I think there's already a couple questions I see popping up, which actually, Lacey, I think some of them are going to come up in your presentation actually around partnerships and the nature of the collaborations for Beacon Community. So that'll be pretty exciting. I've also had the pleasure of knowing and working with Lacey over the last 3 years. She is the director of the Center for the Science of Healthcare Delivery Project Management Office. She is a Project Management Institute certified project manager with a master's in business administration. She directs a large portfolio of research programs, including the HHS ONC Strategic Health IT Advanced Research Projects, known as SHARP, on secondary EHR data use, and of course our Beacon Award for the Southeast Minnesota region, in addition to a CMMI Healthcare Innovation Award, the NIH and National Cancer Institutes. It's been, again, a tremendous treat to work with Lacey because we've just been able to see how the community part of the Southeastern Minnesota Beacon has really come together. Certainly built on a strong foundation of already existing community work, but it'll be exciting to hear more about that from Lacey. Over to you, Lacey.
Thank you, Genevieve. Yes, and thank you all. It's a pleasure to be here today and speak to you about kind of how our approach to a Beacon Community Grant kind of rolled out over 3 years. We do have a wealth of background and collaborations. Although even with my my biography there, it's interesting. We often have grants come in or efforts or initiatives come into a community, and when funding leaves or objectives are met, oftentimes then so do the improvements or the advancements. So that was one of the things we really wanted to look at from the very start of setting up this community, and that's kind of where I'll focus today's conversation. Now, just to give a background of what is our community, we do identify with a geography, and you'll see here that's in that lower southeast corner of our state. And it's made up of 11 counties, 47 school districts, and then we do have in our community integrated health systems, and so that is represented with the different systems there and kind of where they're dispersed. Now, in looking at that just right off the bat, that was one of the things we wanted to make sure we thought about is we were really focused on population health from a geographic perspective. So really caring about our community and the people that reside in our community. Not so much from oftentimes the definition of population health as a cohort or from a provider's perspective, what patients they care for. Instead, we wore a very different lens, and that was we want to care about the community that lives and resides here, and how do we care about their health? And so that was the perspective that we took forth in our Beacon. Now, from a technical perspective, this posed a few challenges because when we look at the community and who we're providing health to, there are different people who can impact an individual's health. And so, of course, there is the provider level, and we have those listed there. Now, they, of course, have valuable clinical data. They also then we found with our systems, they had robust infrastructure capacity, and they also could then get meaningful use funding. And so they have, we kind of listed, they had their requirements. We then looked at our public health departments who also have valuable health data, but they had limited infrastructure capacity, and they, of course, had no meaningful use incentive to participate at the time of Beacon. Beacon dollars obviously helped with that. And then you look at other partners such as our school districts, our home health facilities, our nursing homes. Again, valuable health data, very limited infrastructure capacity, and of course no funding. Now, as you can imagine, when you're laying forth a project, especially one about meaningful use and exchanging health data, you can see there where they could be pushing and pulling each other in different ways. And we wanted to make sure that, particularly those on the left, did not necessarily sway the others or sway the decisions of our technologies to a point where perhaps maybe those school districts couldn't participate. We had to keep in mind that all partners needed to be able to exchange and participate in our community. So what we did do is we invested our $12.5 million into the mandatory HIE, CCD, and meaningful use, but also how do we bring that exchange into the schools? We did have a focus on diabetes, and I'll talk about our perspective was a little different. We actually have lots of diabetes and interventions in our community, and we decided to take a different tangent. If you look at the whole of the patient's health and diabetes, there's the clinical care, there's the lab values, but we really wanted to look at what was in the home, the patient experience, and so we kind of took that angle, and I'll talk more about that. We explored telemed technologies, really trying to understand, while you saw our geographical disbursement, We do have an urban center, but we have a very rural outlier. And in the dead of winter, sometimes it's not easy for those patients to get to the specialist. And so telemed technologies of how they could assist in that healthcare delivery were explored. And then because we did have this population view on health, we really wanted a clinical data repository at first. We then morphed into a community data repository. So how do we have holistic health information about the population that resides here, not just those that receive care? And then, of course, a large focus of investment was in transition of care with our public health. Our public health partners were a key to changing how we deliver health care in our region. Now, one of the keys I wanted to highlight that we really landed on at first was because we were geographically focused and really concerned about our community members, the first thing we did is engage citizens, and this was undertaken in a process we call deliberative democracy. And really that's informing individuals and allowing them to share what their hopes, what their fears are, and kind of weigh in into the end result or end decisions. And we really wanted to ensure that their values and preferences were brought into our project so that it wasn't from just the care delivery standpoint, but it was from for the care, the recipients of the care, what did they want us to achieve. This turned out to be the foundation to our entire project. Hearing from all stakeholders, particularly the community members and their own health, became the most important, and it did change decisions that we made along the way. It changed how we designed our technologies, how we implemented, and who provides care in different innovative models. And so this became a component to our project that we could not undertake any initiative in our program over the 3 years without ensuring that this was done first. So as I talk about some of the different initiatives, that was something we did at every step along the way. We engaged our citizens. The other component to that is engaging patients. And really, this is seen in particular in our diabetes, where we really wanted that patient voice as part of the care. So taking a diabetes patient, oftentimes the clinical decision support, even the information that's exchanged is very clinically centric. It's their lab values. And we really wanted to hear the other side of the coin. We wanted the patient to let us know how they were doing and where they needed help, and whether or not they could manage whatever the care plan was. And so that's where we have patient-reported outcomes as a key component in our care. Now, as I talked about, not only hearing from our citizens what they wanted, from security standards to who had access, what kind of privacy concerns did they have. We also had those 3 community partners, or 3 levels of exchange partners, and we took all of their requirements. And we found that just putting in an HIE infrastructure, a centralized HIE, maybe having it be a vended solution, just didn't work for everybody. We needed to have things that could be scaled down and scaled up and have different security layers and have different people be able to communicate with each other. So what we did leverage is the NUHIN document exchange standards that came out of ONC at the time. Of course, it's undergone many name changes over the 3 years. It's now eHealthy Way. But it did actually allow us, it's a peer-to-peer network, so it allowed us to set up an infrastructure. Not everybody had to pay a similar fee to get onto an HIE service. Instead, they could define who they needed to connect to, those critical partners, and they only had to connect to each other. So we set up this network. Now, 3 years back, this was rather an anomaly, and this was sort of unheard of, and it was not believed that it could scale. And so we were very fortunate to also be in a community that has a large organization that had chosen to participate in what was called a Care and Connectivity Consortium. So major healthcare systems that you can see on the right hand that were utilizing this technology to see if this could do cross-state connections, how does the standard scale, et cetera. And so we were able to participate with this larger group. So as you can see, we did actually connect all of our major health systems who had the gamut of EMR vendors, as well as connecting with our local public health, and I'll talk about how we also were able to connect to schools as well. So one of the things that we looked at, and this is, we actually did not have to leverage the HIE connectivity, but kind of what was the use case. So we started out with who provides care, what does the population look like, and we did find that there is this population that hits our hospital, and you know, there's two things to this. One, either maybe they don't have a primary care provider. So where are we having those heavy hitters, high ED utilizers, and how do we help them get care? The other side to this is we were looking at the readmission rates. Obviously that is something we wanted to be focused on. Can we lower readmission rates and lower that risk? And it turned out that we could if we just communicated with each other. In particular, if we had a client that was admitted to either the ED or the hospital, and they had a public health case manager, that public health case manager could come into the admission process and help discharging before they're even discharged. We found some very relevant use cases right up front. Things like patients come in and the hospital doesn't have the full story. They maybe don't understand that they don't have the care that they need in the home setting when they go to be discharged, and so we need to think about that. That's information that other care providers in the community had that the hospital setting did not. By alerting everyone, we were able to influence that care process and that discharge process, and then reduce our readmission rate. And I don't believe I don't have my numbers here, but we did reduce our readmission rate, both for our asthma population as well as our diabetes population that we were monitoring during the life of the grant. Now, looking at the community data repository, again, I wanted to point out there's a lot of talk of HIE repositories, clinical data repositories, and they are valuable. What we started looking at, though, was the additional information. And so I have in here things like patient-reported outcomes from public health, things like med reconciliation. So some of the things we started to discover when we shared information with non-traditional providers is things like we might know what a patient was prescribed. We may or may not know what they filled. But funny, when the public health client manager goes into the home, we now could understand what they actually took. In communicating this information, we actually prevented some ED visits in our case studies where patients were leaving the hospital not understanding that maybe their med list was their new med list. They were taking their medications that their primary care provider had given them in addition to what they had received at the hospital. And so that's of course a problem. By communicating this information together, we were able to get a more holistic understanding of the patient and then of course work together in their care plan. Now, one of the things that we did do with our repository, this is a little unique to Minnesota, but this gets to a lot of questions about consent. In order to study the information at a geographical level, one of the things we put in place is what we call Minnesota Research Authorization. Now, this is a state mandate that if you're going to use data for research, you need to get authorization. And we did actually use our Beacon dollars to put this in place into all of our participants' settings. So whether that was public health or whether that was with the provider. What you do is, as a patient, you can, with each institution that you visit for care, you can sign an authorization if you're willing to allow that medical information to be shared. Now, of course, there are some times that patients maybe they consent to certain information, but not others. And so we actually have that in our system, and we send that to the repository. So if we are doing studies on our community and we want to look at it for research, and we do deem research looking at the data in order to do surveillance as research, we can only pull the information that they have consented to have sent. This really was supported and endorsed when we did our community engagement. People, when you talk about just exchanging health information, they get very nervous because they don't know what that means. But when we can explain what we want to share, why we want to share it, and with whom we want to share it, the comfort level is much stronger, and the patient is much more empowered to make decisions as to what they would like shared or not. Now, the other setting we looked at, of course, was asthma care, and this was looking at the schools. And so taking into account, having looked at our geographic region and understanding that asthma was the most prevalent in our school-age children, and looking at that they're in school most of the day, we really wanted to enable care where the child is. And that first started with just sharing information, asthma action plans, first of all getting everyone to have an asthma action plan, which identifies an individual's triggers, and asthma is individual. There are different triggers for different patients, and how you treat those triggers and what's the response. Sharing that with those that care for that child or in the care of that child, and of course having parental involvement was key. And then we layered that and enabled that with technology. What was key to us is we realized that there was valuable information in the community that the primary care providers really wanted. So it was kind of interesting having our focus groups in this case where school nurses are telling us, well, this is what we would need to know in order to not just call 911. And conversely, the provider saying, well, this is what I would like to know from the school so that I can have a better care plan for my patient. And they both said, but we don't want to bother the other. But when we brought it together, they were very enthusiastic and started sharing that information. And with this, we saw a huge increase in ensuring that all of our asthma children had plans, had up-to-date plans, and the communication was shared with all. Now, this is where that consent model came into play and became very critical because, of course, we need to be able to enable the care or the sharing of information to only those that need to know. One of the things that was thought initially in the design from the technical teams is let's make this available to the entire school. I mean, when coaches need to know that this child has asthma. And we heard very loudly and strongly back from the parents that no, indeed, they do not want that because they did not feel coaches would have the appropriate training or understanding of the care plan. It should be filtered through the school nurse. And so we, of course, built in those protocols so the school nurse is the first to give the information, and it's up to the school nurse to then translate what the coach would need to know. With that, I did want to just mention, so we actually we got significant coverage of our community where asthma action plans are in place. We also, very early on in the electronic exchange, we did start preventing ED visits because the school nurses had a plan to react to, as opposed to if they didn't know, they sent them to the emergency department. So we had a huge improvement of the care. We also found asthma action plans are done annually in Minnesota per our own guidelines, but we found that particularly with new asthmatics, those plans often needed to be changed within the first couple months. And those were now proactively changed based on feedback from the school nurses, letting them know that the care plan wasn't completely appropriate. For example, the student might have been in the office 3 or more times that week where they were uncontrolled. We got that information much sooner and were able to get appropriate plans in place for those students. So some of the keys to our journey as we made those improvements, enabling community interactions, enabling the ability to exchange health information as well as community health information. It really was the shift from being provider-centric to patient-centric with a community-driven commitment. So really surrounding the patient with what one of our clinicians coined the cocoon of care, and then enabling that from the provider and technology perspective. Now, how do we do that? Well, we did have a community governance model. So we from the start, we established a legal framework in a community governance. We conducted the deliberative democracy community engagement process throughout the grant. We empowered communities of practice, and I genuinely mean empower. When we started with the schools, school nurses did not feel they had a voice. Right now, they actually not only have a voice, but they are an entity. So our School Nurse Association in our region is an entity. Any new projects coming forth, they can go to that entity and work with them, and they have an equal voice along with their other the practice providers. And the same as we're moving forward in our sustainability plan, we are now working with long-term care and mental health centers in the same capacity with the same process. We also, of course, had technology and health delivery solutions that enabled the sustainable approach. So by taking into account all needs and coming up with solutions that could be more flexible for those needs has allowed us to sustain. Interestingly enough, that is also coming at a much lower cost for many of us. So the lenses we wear, again, we're patient-centric. Patient-reported outcomes with quality of life measures are proactively gathered now for our chronic disease management. So what I mean by that, I didn't go into a whole lot of detail, but we really capture the patient-reported outcomes. So what's our quality of life on a scale of 0 to 10? And that's another gauge, no different than any lab value. If your lab value goes askew, you act on that. We do the same thing with patient-reported outcomes. So if we see that your quality of life has significantly dipped, that's a trigger for us as to come in and see what is happening. Now that trigger actually triggers public health and primary care providers to work together. So we have built our response mechanisms from a community perspective on behalf of the patient, which then gets me to the community-centric. Our tools were built from a community perspective. So our school portal, which allows all of that sharing, that's actually housed by local public health. And then, of course, you can see that that's resulted in our ED rates. There's my numbers, significantly dropping. Now, what this has also done from a community view is it has challenged our perspective on how we deliver care. So, for example, with looking at the schools looking at asthma, we realized that when we wanted to do influenza and we wanted to increase in our student population, it was actually more effective to deliver those immunization clinics at the school as opposed to having them come into the provider office. And so we've shifted how we deliver that care. Now, with everything I talked about in this community perspective, we certainly had to have legal considerations. And so I didn't want to be remiss. I wanted to point that out. We did have business associate agreements between or among all of our participants, so all of those individuals that I discussed. We also then had a Beacon Consortium and Data Repository agreement of how are we storing all of that data, what's being exchanged, what's being stored. So we did have that in place. We also ensured privacy compliance from all the different realms. So when you go outside of the healthcare setting, looking at the schools and looking at public health, there are different privacy rules to consider. And of course, we had the FERPA and the DPA. Oftentimes, they're overlapping, but there are nuances that you have to be aware of, and we had to build that into our technology. We had to be able to account for that privacy compliance. One of the biggest challenges we had then was in consent and authorization. So ensuring we...
Welcome to GoToWebinar, Web Events Made Easy.
Consents, multiple authorizations, but yet we wanted to make sure we're compliant. So we did walk through a lot of scenarios. What if the school obtained it? What if the provider? What if? And so we had to have a lot of different scenarios. At the end of the day, we actually had to enable it to happen at multiple endpoints. But then be able to exchange not just the information, but the consent and the certifications along with that, so that if I was at a receiving end and they'd already signed a consent, I could see that and see what they consented to, so I wasn't asking for an additional consent, or if I did not see that, that I did ask for that additional consent. And then we did actually have a regional exemption with our state. Our state has some regulations around health information exchange and what information you can exchange and for what reasons. The laws were built around a traditional HIE and did not account for even just the peer-to-peer network or some of the scenarios that I talked about. So we did receive an exemption during the Beacon period, and now those laws have been adjusted to account for other scenarios besides a traditional hub-and-spoke model. But that is a disclosure that we had that exemption. So all of our information is out on our website, and I'll apologize, we're actually right in the middle of changing all of our website. But what will remain the same are the tabs. So what we're putting out on our website now is less about what the project was about and more about the results in the toolkits. So all of the things I talked about from deliberative democracy or community engagement, we're putting out on the website how we did it, what we did, and then the toolkit if your community would like to try that too. And we found that while we worked collectively as a community to really go through these efforts, some of these things can be done without the whole community. So things like putting in the patient-reported outcomes into your practice can be done without the whole community. We put those tools out on the website, and you can learn how to do that. So I did want to point out, it is in transition as we're moving into getting that updated, but that's where you would find, if there was something of interest, you can go out there and look at that component and then get the tools yourself. So with that, I thank you, and I'm open for questions along with Trudy and Genevieve.
Lacey and Trudy, this is Genevieve speaking. Thank you so much for the presentations. There's a ton of fantastic questions, and I thought what we might do is, Lacey, there's a couple follow-up from your presentation, so I think we could start there. And Trudy, of course, if there's insight you have, jump in as well. And then I think, Trudy, there's a couple of specific ones that seem to have generated from yours, so we'll work backwards. So first, Lacey, there's a ton of interest in patient-reported outcomes and patient engagement, and specifically, how does Southeast Minnesota patients submit patient-reported outcomes electronically? That was one question. And then just, I think, a general, more in-depth look at the types of measures that you're looking at.
Mm-hmm. Yeah, so patient-reported outcomes, we actually have a scientific office that had been focused on that, and there's different societies that have worked on that. There's things like PROMIS measures. One of the things we did find when looking at a lot of these measurements on getting either their patient-reported outcomes or their quality of life measures, most of the surveys are several pages long. So we did take all of that, and we did actually map our end result. Our end result, hearing from clinicians, hearing from patients, is that they really only have the capacity in any workflow or any time frame to answer no more than 10 questions. And so we scaled back what we ask. But it's interesting, what we ask essentially is, how are you doing? What's your biggest concern today? And what's your quality of life? And we do ask a few questions like, what's your burden of care? But that information oftentimes is even gathered now in conversation. This is just a structured way of capturing it. Now, when we set out to do this, we really thought this should be captured in the provider setting. We thought that the provider should have immediate knowledge of where they're at and have tools to respond. Let's say I said money is a big concern right now. I can't afford my medications, and what do I do with that? And giving the clinician the community tools of how to respond to that. Interestingly enough, in all of our pilots, we found that's not actually the place to do it. Patients, first of all, logistically it was difficult, as well as patients at that point have been trained to come in to talk about their actual clinical issue. They're really not thinking so much about the day-to-day burden, or they don't want to tell their clinician that this is a burden. So it actually turned out the best place to collect it was in the home with our care providers, whether that's a care manager, whether that's a local public health, or whether that's a mental health provider, some community member. Or you can put it into patient portals if your system has that sophistication. So we've started collecting it at a community level, and it gets reported back to primary care when there's a flag or something that triggers a response. For our large healthcare systems, that's usually triaged through a care manager. So that's how we've incorporated it. But it was a learning process and a journey. And then once you enable it and you want to build that into your systems, you do need to map that to other standards. So we've developed, if you're familiar with terms, we've developed LOINC codes for this so that we can have this interact with our systems. Hopefully that answered it. Otherwise, just prompt me, Genevieve.
Yes. I think that's great. We'll probably see a couple more questions pop up, Lacey, if there's follow-up to those. Mm-hmm. So there was a question about partnerships, and I will ask both of you to just comment on these. Lacey, you spoke to this in general, and it was partnerships, I think, in terms of at the community level, the non-medicalized community, if you will. So Lacey, you talked about public health and schools. I think there is a question also about ADRCs and other community-based organizations. And there's a question about FQHC engagement, trade association engagement. And I just wondered if both of you could maybe speak a little bit about, beyond what you already presented, but how you're thinking about, particularly, again, some of the, I don't want to call them non-traditional, but I would call it the more community-based, less medicalized partnerships that are so critical for population health. There have been quite a few questions with that. And just, I think there was a specific question about the nature of what the Beacon Community Program required. Just to clarify, we actually there was a requirement for this truly to be a collaborative with several stakeholders beyond just, say, hospital partners, but we did not specify what those partners needed to be. So you heard from Lacey that in their community, their goals really included engagement of the public health community. In other communities, that meant engagement of, I mentioned EMS, and sometimes it meant purchasers. But we were looking to the leadership of communities to be able to define what that collaboration looked like, and knowing that it needed to be multidisciplinary. So, and there was no requirement, for example, to absolutely include FQHCs as a requirement as part of the program. Trudy, why don't we start with you about this sense of how you think about partnerships when you think about population health moving forward, the need for some of this broader engagement to happen.
Well, thanks, Genevieve. There's a couple of different layers I would mention regarding this. First of all, we've been very fortunate to have on our board and as a very active participant and supporter of health information exchange and the use of technology for improvement, the Hamilton County Public Health Commissioner, Tim Ingram. He has been a very engaged member of all of our work, and I mentioned the 3 organizations in our community that that are now all kind of working together under a single set of leaders. And so we've had very good involvement from public health. I will say also that health plans and employers have also been really engaged under our Beacon work. In particular, several of our large employers in the community, GE and Kroger, were very supportive of our population health efforts. Kroger was the rollout site for our Text for Health program, which targeted folks with prediabetes, and they were very supportive ongoing with the program. GE supplied $1 million of in-kind through a loaned executive, through quality improvement experts in the practices, and through some additional communication support and other types of supports to Cincinnati. And we're really focused on how do we improve the health and wellness of GE employees, but also, all of, greater Cincinnati, and just really seeing themselves as a resident in that community and how they could use this as a prototype to spread to other communities. And, so we were really fortunate in that regard to have some of these non-traditional partners. Part of that came about because the Health Collaborative, as a quality improvement and community convening organization, has had such a strong multi-stakeholder presence in the community for a long time. So if you're working in communities that that or in regional areas that don't have that type of a partnership, then it's really important. Like I would lay the fact that we were successful in getting a CPC project in our community at the door of the collaborative's 20-year investment in collaboration around quality improvement. And it really, you know, if you don't have one, you may think, well, I don't have anything nearly as close to what Cincinnati has. But, you know, there's no time like the present. You underestimate what you can, you know, you overestimate what you can accomplish in 1 year and underestimate usually what you can accomplish in 5. And so at some point in history, Cincinnati didn't have this infrastructure, but we began developing it, and it's made all the difference these many years later. So it really is, you know, having those multi-stakeholder collaborations are really critical, and then you have to really target your interventions around who are the engaged folks at the table, and that's what we've tried to do. So hopefully that's helpful for you all.
Thank you, Trudy. And Lacey, anything else you'd like to add about community engagement, especially when you look forward and the needs to support population health?
I have to echo what Trudy said. I mean, we had a lot of other engaged parties as well besides the ones that we target our interventions. But you know, we actually get asked, we tend to speak a lot at public health events, and we really want to encourage people that if you're putting the community or the patient in the center and you're looking at what the community infrastructure is, you start to think very differently. And it's just, you don't need a Beacon grant dollars to do it. There's actually, we found that outside of our Beacon grant program, that there was need for community partners to work together, and they found cost efficiencies by working together. They found better ways of delivering health care by working together. So just a quick example, when it came to education, of course, obesity is a huge issue. And, you know, educating people on how to eat well and making sure that the community resources were available. It was something of great concern to our providers, but the best enabled people to do that were actually our community partners. And so in working together, they're able to find efficiencies. They're able to impact healthcare in ways that you really just can't think of from a provider-only view. But yet the provider is very interdependent in that. Interestingly enough, too, don't always think about who provides the care now, but who has the biggest influence. In our community, we actually had a lot of religious groups that had the most influence as to whether or not the patients would participate or who they would go to seek care from. And so we worked very strongly with them as well to just understand their community and understand where best should that care be delivered. So just when you kind of, you know, take off the badges and take off the where you come from and kind of just sit down in the community and say, how do we have better health? It's amazing what cards people hold and how you can find those efficiencies. I often tease in our school group, we all came in with our badges and we all came in with our preconceived ideas of what we should do. And by the end of the Beacon, I swear people was like, here, I'll give you that hearing test if you'll give me that asthma action plan. And so you start to think very differently when you just start communicating.
Very well said. Very well said. There is a question here, and I think, Trudy, maybe you can speak a little bit about this. It's a multiple part question, but I'm going to pick out a couple of them. And the heart of the question, I think, it's involving bringing competitive institutions together to really do some of the hard work if we're going to achieve the aims around population health. And I think that can be everything. The example in the question is, what are key determinants of success required to bring competitive institutions, e.g. university and private IDN, together with agreement to share care planning? What about competitive physicians across subspecialties? So that's I think when we think about improving population health, improving care transitions, it is the sharing of information, it's the sharing of expectations. And Trudy, I wondered if you could talk a little bit about the experience and journeying of Cincinnati. I know it started before the Beacon Award, but certainly there's been a lot of acceleration with your care transitions work as part of Beacon.
Yeah, and I think one of the testaments to the fact that things did work under Beacon was at the same time that Beacon was going on, we had tremendous change in our marketplace. One of our large health systems that was kind of a federated health system blew up and was, the hospitals got bought by different competing folks at the same time. Our market went from being about 30% employed to being more like 60% employed. So physician practices were being bought up right and left. Electronic health records, of course, were being implemented, and all of this change in the marketplace was happening. And folks have frequently will say, "Well, this works in Cincinnati because you guys are also collaborative." I mean, let me tell you, it is around these tables. There are some tense discussions about what is going to get in the grill of the health systems involved in this collaborative work. To their credit, a lot of on the transformation work, they figured out a way to collaborate around the things where they're not competing. They compete fiercely for market share for patients. But around infrastructure elements, they understand that that's a way to lower costs. And we've done enough work in the community so far that it's not as hard to sell as it was in the beginning. And so, in our marketplace, again, there's been a lot of changes, a couple of different factors that make a big difference in how much skin in the game these very competing partners want to have. I think it's been absolutely critical to have folks like our public health commissioner and our employers around the table, really forcing these fierce competitors to do more collaborative work together. And some of these large employers have put a lot of muscle behind the collaborative work that's happened in our community. And then public health has had such a great role in really reminding everybody about the role of the patient and saying, really be standing in the stead of the community and the patient and, helping people to do what's right, even when, down the road, there are two health systems slugging it out for market share in a particular sector of the community. And or putting another billboard to try and steal each other's patients, So, so that has been our experience, is that those outside influences are absolutely the game changers and the willingness of providers to participate and stay in a collaborative relationship. I can't, underemphasize that enough. Then I think the biggest areas where we've seen growth is in the willingness to collaborate on the sharing recently of claims data, because that's an area where healthcare providers know that they don't have a full view of their patients. They're not going to be able to solve this problem on their own. And an example of some of the ways where providers are willing to collaborate is because they can't solve it on their own. It has to do with the sharing of different kinds of data. So, for instance, Cincinnati Children's had a long-standing asthma improvement initiative that had focused on reducing unnecessary ED utilization. Well, they came to the table as a strong partner, 70% market share in the pediatric market, basically saying we've done all the work that we can do internally to improve ED admission rates. Unless we have the other hospitals in the community willing to work with us, we are not going to be able to drive down these rates anymore because we can't see where the utilization is happening outside the four walls of our institution. Now, of course, that gets into a business of, are we really going to share information with one another around, ED visits for asthma? Cincinnati Children's has 70% of the market. The rest of the 30% is divided pretty evenly among the other participating hospitals. We were as surprised as anybody else that the hospitals, the other hospitals in the community said, yeah, we're willing to share this data with one another because this needs to be, and it needs to be done all in. So all 6 health systems said, if one is going to do it, we've all got to do it, because this otherwise it becomes, other people get a view into your utilization data. And so all 6 joined in. And now, basically while we started with diabetes and asthma for alerting and understanding our ED visits, readmission rates, now these things are being rolled out across the community for all conditions. So again, we started with something that was doable and then spread it from there, but it is continuously an evolving trust relationship. And so those factors of kind of external pressure and working on business problems that the providers can't solve themselves are two critical factors. So, hope that's helpful.
That was helpful. Thank you, Trudy. I'm going to scroll down, actually skip to another topic that's coming up in a couple of places about multi-vendor environment and how that works. So it was related, Trudy, to the question that you answered, but also I think just curiosity about what your vendor environment's like and what method of engagement did you use? I know we talked about this a little bit, but this is certainly something I'll just mention from the ONC's perspective. There was a very interesting effort pulled together by many Beacon communities to work with a targeted list of EHR vendors, because there was a shared belief that if they could focus together on some interoperability and exchange goals, set priorities, then everybody would benefit over the course of this program. And that is something that I know moving forward, everyone's very much still focused on, considering the broader reach of HIE goals tied to meaningful use stage 2. So Lacey, why don't we start with you, maybe talk a little bit about your any vendor insight strategies, especially thinking about diverse marketplaces, and then Trudy, any other comments you'd have on vendor engagement and strategies.
Sure. So we did have the run the gamut of different vendors, and it's certainly not for the faint of heart to work with the vendors. But this is actually the ideal place of banding together. This is the ideal place where we work together as a community, a common voice, common institutions. We could then, we had much more leverage with our vendors than individual institutions asking for change. And this is where we did then partner, and we were a very strong participant with the national effort working with the vendors to really have this common voice of what do we need and why. And it was not easy even for all of the Beacon communities, because there was only 17 of us. So while the rest of the country was only focused on the basic needs, the vendors were only putting in meaningful use 1. Well, we were Beacons. We're in meaningful use 2 and 3. We're the future. And so oftentimes they'd look at us and kind of shake their heads and say, well, why would we make that change now? We all have all of our resources deployed. And we really had to band together and show why we needed what we needed. We also had to show what the value was. What would our clinicians be demanding next, and how would that help them, and what would they be willing to purchase, and how would that influence their vendor decisions in the future. And that's kind of how we made some momentum. I can share we would have liked to have made much more momentum, but that was how we did it, was a common voice.
And Trudy, thank you, Lacey. Trudy, what's been happening in Cincinnati? I know you and I think your vendor environment, it is a little bit different, and you came to the Beacon program with a strong exchange already there, and can you share a little bit about what's been happening?
Yeah, so our Health Information Exchange is more than 15 years old. So just in the last 5 years, the Epic, our 6 major health systems all use Epic for both inpatient and outpatient, but that wasn't always the case. And then we have really, that sounds more like a single system than what it really is, because we do have 40 different types of inpatient systems that we connect with. So while they may, use Epic for their inpatient and ambulatory EHR, they might have a different lab system, or their registration system might be different, or there's just a lot of different IT systems that we're connecting with. And again, it's 40 different inpatient systems and more than 70 different ambulatory electronic health records. So, one of the things that we found, our Health Information Exchange uses largely HL7 connectivity for labs, radiology, transcribed reports, and ADT data, so admissions, discharge, and transfer information. And that has really been a wealth of clinical information, and was the kind of key driver of us getting this connectivity. So, for most providers in the community that have an electronic health record, they're getting structured data into their EHR in a machine-to-machine readable format. But that took us a long time to build. I mean, we started doing this work in the early 2000s and have built it gradually over time, and certainly we've had a flood of new EHRs that we've had to deal with in the last few years. I think, you know, our principles for how we've dealt with this kind of, you know, tidal wave of connectivity that's been needed is we've always begged, borrowed, and stole from national standards. So don't, you know, try and build community-based standard if you can possibly help it. Always really focus on national standards. So that's why, for instance, we're also implementing Direct, and we are a health information service provider. You know, again, to help us with that, you know, connectivity, really building on those national standards. You know, we also one of the things by coming together as a community, and especially in the early days, all of our health systems basically said, you know, we're going to have a standard interface template that we implement across our community. So as an electronic health record vendor came into the marketplace, you know, a lot of them would say, here's our standard spec for doing interfaces. If you want to run EHR in this community, this is what you have to abide by, particularly with labs. You know, there were some lab vendors that wanted to, you know, not work with HealthBridge at all, and basically our hospital said that that's not going to fly because this is the way we've decided to share information. If you can't send information via this lab specification, you know, you won't be our lab vendor, period. And so that made them, you know, willing to change the way that they implemented a lab information system. So I think that collaboration can be a very strong driver of working with vendors, and, you know, versus doing things just by yourself. You have as much power on your own.
Thank you, Trudy. And it looks like we're about at time. There were this has been, I mean, it is always fantastic to hear the latest and greatest from Trudy and Lacey. I wanted to ask the team from the PCPCC, though, there's a ton of questions here that I don't know that we got to all of them. It would be wonderful to share them with Lacey and Trudy, just to make sure that we can follow up. And certainly from our perspective, we're very happy to share whatever information, slide decks, et cetera, with everybody. But I wanted to offer my thanks on behalf of the ONC to the PCPCC and everyone who joined. This has just been a wonderful, wonderful opportunity to hear the discussion. Trudy and Lacey, my thanks as always for your tremendous work and for sharing your insights with the group as well.
Yeah, thank you
Glad
so
to be a
much,
part of
Genevieve.
it. Thank you.
Yeah, thanks again, Trudy and Genevieve as well, and Lacey certainly. Thanks for a great presentation. Just a reminder, we will have the presentation available up on the website. We'll make sure that all of you get a copy, all of our presenters get a copy of the questions that we weren't able to get to, and we'll post some of those answers up on the website as well. Just a final reminder for those of you who haven't registered for our conference, remember right after this webinar, if you go to our website and register and type in code 9WEB2013, the number 9, WEB 2013, you'll receive $100 off of our registration for our conference. So thanks again, everyone, and have a wonderful day. Bye-bye.